السلام عليكم ورحمة الله. إن شاء الله. So we discussed before the pathway, the CSF pathway, in the previous lecture. This is a more non-diagram. This is an MRI T1 sagittal cut, uh, where here we can see the lateral ventricle. This is the third ventricle here. Aqueduct of Sylvius there. The fourth ventricle, and the aqueduct and the foramens. Media in the midline. There's a foramen of McGinty, and laterally the foramen of Lutschke's, two foramens. So, what is hydrocephalus? Hydrocephalus is an abnormal accumulation of CSF within the ventricles of the brain. Okay, now it's simple as that. What are the types of hydrocephalus? Two main types of hydrocephalus. The first one is obstructive hydrocephalus or non-communicating. The second type is communicating hydrocephalus or non-obstructive hydrocephalus. These are the two main types of hydrocephalus that we want you to know. And these two types are due to decreased CSF reabsorption or due to obstruction of the CSF pathway. And this will lead at the end to decreased absorption. Okay, so obstructive hydrocephalus or non-communicating, there's a blockage in the CSF pathway that is proximal to the arachnoid granulation. And what do we mean by proximal to the arachnoid granulation? So anything that blocks the CSF pathway from the lateral ventricles to the foramen of Monro to the third aqueduct of Sylvius, fourth ventricle, all the way, anything that blocks the CSF pathway just before the CSF reaches the arachnoid villi, this will cause obstructive hydrocephalus. Okay, now communicating hydrocephalus is hydrocephalus or accumulation of CSF in the brain due to decreased resorption of CSF by arachnoid granulation. So there's no blockage of the CSF pathway. There's a decrease in CSF resorption. Okay, now in obstructive hydrocephalus on CT or MRI, we will see enlargement of the ventricles proximal where to the blockage itself. Okay. Um, Mainly or most commonly, excluding the fourth ventricle. Okay. Sometimes we refer it as triventricular. Tri, so it's involving the two lateral ventricles and the third ventricle. So three ventricles. Triventricular hydrocephalus. Communicating hydrocephalus, usually it uh, the fourth ventricle is dilated. Okay. Now, rarely there are some situations that might cause overproduction of CSF, in which case just know any tumor of the choroid plexus that is responsible for the secretion of CSF, for example, choroid plexus papilloma or carcinoma, which is a tumor of the choroid plexus cells. This will lead to increase in the number of C cells that are producing the CSF. This will lead to overproduction of CSF and causing hydrocephalus. Now, so if you see an enlarged ventricles in the CT or the MRI, either it's a communicating or non-communicating. Okay, if it is non-communicating, so the obstruction of the CSF pathway is present, and this is called obstructive hydrocephalus. Communicating hydrocephalus, either there is obstruction to the absorption of the CSF, okay, or the absorption of the CSF is obstructed. Okay, just concentrate on these two types, the obstructive hydrocephalus and the communicating hydrocephalus, due to obstruction of the pathway, due to decreased resorption of the CSF. Okay, just focus on these two types, please. Okay, so here, this is a CT scan, axial cut, brain tissue window, non-contrast CT scan. Here, what we can see. So, as you can see here, the lateral ventricles are severely enlarged. Okay, this is what we want from you. There are other findings, but what we want you to notice is that there is an increase in the volume of the lateral ventricles over here. Okay, this is another example. Dilatation of the frontal horns, the lateral ventricle. The third ventricle is severely dilated. The occipital horn here and here is also dilated. Okay, this is hydrocephalus. Okay, good. This is an MRI. So this is an axial cut. This is a coronal cut. This is a sagittal cut. This is T2 weighted MRI. This is a T2 weighted MRI. This is a T2 weighted MRI. Why? Because the CSF is hyper-intense. It has this high signal. It's bright in the ventricles here and here and there. Also, the CSF in the subarachnoid space in the gyri here, 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 and there. Okay, so enlarged lateral ventricles, enlarged right lateral ventricle and left lateral ventricle, and dilated third ventricle here. Okay, here if we look at the fourth ventricle, it's not dilated. Okay, so most likely the obstruction is here in the aqueduct of Sylvius. That's causing obstruction of the pathway of the CSF to the fourth ventricle, causing triventricular hydrocephalus. So this is an example of obstructive or non-communicating hydrocephalus. If the fourth ventricle was dilated, this is how we diagnose communicating or non-obstructive hydrocephalus due to decreased resorption of CSF in the arachnoid villi. Okay, apply basic knowledge here to there. So dilation of the lateral ventricle, the third ventricle, and here the fourth ventricle. You might find it difficult in the assessment of the fourth ventricle. With experience, you will know how to say if this fourth ventricle is dilated or not. Okay, but in this sagittal cut, we see the lateral ventricle is dilated and the third ventricle is dilated. So this is communicating hydrocephalus. As you congenital is secondary to masses, for example, is if there's a vascular malformation, a brain tumor that's causing obstruction of the pathway of the CSF, or patients after surgery. For example, patients with cerebellar tumor or posterior fossa tumor, they have a risk of to develop hydrocephalus after surgery, require shunt. 20% of them will require that. So if you operate on 5 patients with cerebellar tumor, glioblastoma, pilocytic astrocytoma, or other tumor, and you resect that tumor and everything went well during surgery, one of these 5 patients will end having a VP shunt. Okay, so going back to common signs and symptoms of uh, hydrocephalus in young children. So abnormalities in head circumference, as we said before, irritability, because these patients will have headache, and due to high intracranial pressure, these patients, they can't say that they have headache, so they will get irritable. Vomiting due to increased intracranial pressure, full and bulge fontanelle, anterior fontanelle, enlargement and engorgement of the scalp veins, and as we said before, sixth nerve palsy. McEwen sign. McEwen sign is just know it's a cracked pot sound when you percuss over the dilated ventricles. Okay, just we do percussion over the area where the lateral ventricles are present, and we just hear a cracked pot sound. Okay, sunset eyes, and I think the last one is splaying of cranial sutures. So when you palpate the coronal or sagittal or the lambdoid sutures, you might feel that these sutures are splaying. There's a space between these sutures. Okay. Um, Other symptoms of signs. Sorry. or symptoms of increased endocrine pressure, papilledema, headache, nausea, and vomiting, gait changes, up gaze or opposite pulse, as we said before. Okay, good. So now we know about hydrocephalus. What are the common symptoms and signs? What are the causes now? How can we treat these patients? So we have three surgical options. The first one, what is called endoscopic third ventriculostomy, shunting and eliminating the obstruction. We'll go through them. So let's start with shunting. Shunting is a procedure where you insert a device to create an alternative pathway. Okay, um, we'll see an example now. So one of the most commonly used is a ventriculoperitoneal shunt, which is a shunt communicating the ventricles, the lateral ventricle mainly, down to the peritoneal cavity. Okay. Second type is ventricular-atrial shunt, down from the ventricles to the atrium of the heart, which is called a vascular shunt. Okay. When we use ventricular-atrial shunt or a VA shunt, when we can't put a ventricular-peritoneal shunt. Okay. Uh, when, for example, if the patient has an extensive adhesions inside the abdomen due to previous abdominal surgeries or peritonitis, for example, in premature babies who has uh, uh, necrotizing enterocolitis, for example, there's abdominal infection, you can't put a foreign body like a VP shunt in this patient. Okay, so this is here an example of a VP shunt or a shunt, most commonly used ventricular peritoneal shunt. So three parts. This is what we call a ventricular catheter. This is the valve, and this is the distal catheter, either inside the peritoneum most commonly, or the heart or the lung. Okay, so the ventricular catheter is the same as the short catheter, the valve, and the long or the distal catheter. Okay, so this part goes into the ventricles. This part, it controls how much CSF is drained, and this is the distal catheter where it drains the CSF into the peritoneal cavity. Okay, here. Good. This is a not excellent CT scan. So this is a CT scan. I mean, the quality of the CT scan. So this is an axial CT scan, brain tissue window, non-contrasted. So here how we see the catheter of the ventricular catheter. Okay, so this is part of the ventricular catheter. Why we can't see the rest of the ventricular catheter? Because it enters in an oblique way, or in, yes, let's say an oblique way. So this cut, it goes through this end. If you go higher up with this cut, you can see, for example, this part of the shunt. And if you go higher up, you will see it there. But imagine that it goes from here to there, just, and it goes and connect to the valve here, just between the bone and the scalp, or inside the scalp layers, and it goes down to the peritoneum. Okay, good. Now, these shunts, they are foreign bodies, and you are inserting a foreign body inside the patient's uh, body. Okay, so this foreign body is prone to problems. What are these problems? One of the most common problems are obstruction. So obstruction is the most common cause of shunt malfunction. The obstruction is either in the proximal catheter or the ventricular catheter, most commonly, or the valve itself, okay, or in the distal catheter, okay, in the peritoneum, for example, or in the atrium, okay. The second problem here, sorry, should be in separate line, is a disconnection. Okay, so these parts of the shunt, they came separately, and we connect them during surgery. So whenever the problem is disconnection, when you connect these parts, okay, or they might break, for example. Third problem is infection and other rare problems. For example, the patient might have allergy from the silicone, uh, which constitute the major material of making the shunt. Okay, so there will be inflammation around the area of the surgery, redness, and sometimes erosion through the skin. Seizures, because you are operating and irritating the cerebral cortex. Overshunting the shunt might drain more than what we want. So the patient might develop uh, a low intracranial pressure symptoms, okay, or might develop subdural hematoma or subdural hygroma. Okay, so let's go to the second surgical option, which is endoscopic third ventriculostomy. So in this procedure, just know that we go using an endoscope through the lateral ventricle and we create a stoma between the third ventricle and the subarachnoid space in front of it. Okay, so we create an alternative pathway intracranially. We don't insert any object, any shunt. Okay, the CSF pathway is obstructed, for example, in the foramen of Monro or the aqueduct of Sylvius. You create just another track. Okay, um, so it's used in obstructive hydrocephalus. It's not used in communicating kind of hydrocephalus. There's no solid data on the outcomes or the benefits of ATV in communicating hydrocephalus. Okay, so this is another option in treating patients with that. Okay, now going to two small topics, which are the spina bifida, myomeningeal and meningocele. So the types of spina bifida or spinal dystrophism that we want you to know. These are two common examples, okay? The spina bifida occulta, meningocele, and meningocele. Spina bifida occulta, from its name, occulta, it's not obvious. It's a congenital absence of a spinous process, uh, mainly in the lumbar spine, okay? Uh, so absent a spinous process with or associated with the absence of the lamina or not, and with the absence of part of the lamina or the whole lamina. Okay, usually these conditions are diagnosed incidentally. For example, you have a patient with low back pain, you just do an X-ray, um, you find that the patient has a spina bifida occulta. It's asymptomatic, does not cause any back pain, any low back pain, etc. Okay. So the overlying skin usually is normal. You might have some abnormalities such as tuft hair, some pigmentations over that area. Now, meningocele and myelomeningocele. So these conditions, they are not occultus, they are apertus. So these are obvious. You can see them. So the meningocele is a congenital defect in the vertebral arches, the posterior arch in the spinous process, the lamina, and the overlying skin and fat tissue, with cystic distension of the meninges, but with no abnormality in the neural tissue. One third of these patients will have neurological deficits, mainly weakness, muscle weakness. Meningocele is a congenital defect in the vertebral arches, as we said, similar to the meningocele, but this sac of meninges, it will have a neural structure, such as spinal cord or nerve roots. So spina bifida, this is spina bifida occulta. There's no spinous process, or sometimes without lamina. The skin is normal. Sometimes you might see a tuft of hair or a hyperpigmented skin. The meningocele, there's a dura here. Okay, it bulges outside. Okay, there and goes inside. There's no neural elements, as you can see here. Myelomeningocele, from its name, there are either codequina nerve roots, for example, or if the defect is higher up, there might be a spinal cord. Okay, spina bifida occulta, it occurs in around 5 to 10% of population. The defect may be palpable. Okay, if you palpate over the tuft of hair area or hyperpigmented skin, you might feel that there's no spinous process. Okay, often incidental finding might be associated with other congenital anomalies, rarely, such as diastematomyelia, just know that by name, tethered cord syndrome, lipoma, or a dermoid tumor. Myelomeningocele, so this is a baby with a myelomeningocele. This is a dura, okay, with overlying very thin layer of skin. Um, and inside we can see this white thing over there is most likely neural elements, okay? So the incidence of spina bifida, either meningocele or meningocele, is 1 to 2 per 1,000 live births. Okay, the risk increases if there is one previous birth with meningocele and if there is a family history also. Okay, or especially from the mother side. For example, if you are in the clinic and the family has a family history from the mother side with of meningocele, or the same family has a baby with a meningocele or a meningocele, this incidence will increase. Okay, so meningocele and hydrocephalus, it develops in around up to 85% of patients with meningocele. Okay, so these patients are at high risk of developing hydrocephalus and the need of shunting procedure. Also, 5 to 10% of meningocele patients have clinically overt hydrocephalus at birth. Okay, okay, good.